recorded.
Welcome to Jefferson Search and Rescue bloodborne pathogen training. This is an annual training that we're required to do by the laws that we're going to talk about in just a moment. The most frequently required training that we have to do. So that's why we've recorded it here and created the online test that you can complete on your own time. What are bloodborne pathogens? They are disease-causing organisms found in blood and in other bodily fluids, other potentially infectious materials. Examples are HIV, 3 types of hepatitis, malaria, syphilis, and 20 other things. Workers may be at risk for occupational exposure to bloodborne pathogens. Workers in this case means Jefferson County Search and Rescue volunteers. And especially we're going to focus on hepatitis B, C, and HIV. Today's training objectives, overall our objective is to cover everything required by L&I law. We have to do that to stay legal. So, but overall we're going to recognize the presence of bloodborne pathogens, know what to do to protect yourself in SAR environment. We'll discuss different types of bloodborne pathogens and how they're transmitted, identify methods that we use to control exposure to them, and talk about what we need to do if there is an exposure incident. So first, the law. The OSHA federal law was adopted in 1992, requiring this training and everything else described herein. The Washington Administrative Code section, which L&I is in charge of, was adopted later and approved by OSHA. So the WAC, WAC, and L&I apply here in Washington State because we're an L&I state rather than an OSHA state. The WAC requires employers to protect employees with potential exposure to bloodborne pathogens. That includes our volunteers. It requires annual training with these elements, including the explanation details contained in this training, access to a copy of the WAC, an explanation of how to obtain the exposure control plan, which is this document that you're looking at on the screen, and an update if we change anything. So what are bloodborne pathogens? I mentioned it's pathogens, infectious diseases that may be found in human blood, and OPIM, other potentially infectious materials. And you can see the list of other body fluids here. So a few things are not generally considered OPIM that come from the body. In case you're interested, saliva, tears, urine, and feces. However, you can assume in a couple of those cases that they're contaminated with blood, whether it's seen or not. Transmission of bloodborne pathogens occurs through a break in the skin or something penetrating the skin. So contaminated instrument injuries, that would be a needle stick or any kind of cutting implement that penetrates your skin. They can also enter through any kind of break in the skin and through the mucous membranes, particularly in and around your face. Intact skin, if you have fully intact skin without any single cuts or abrasions on it, it can prevent or will prevent the transmission of bloodborne pathogens. But for one thing, our skin's not generally entirely intact, especially on our hands. And we tend to touch our face with our hands. So it's a reason we don't just trust our skin like the old days. So next we'll talk about different common bloodborne pathogens, most notably here the 3 types of hepatitis. So hepatitis A, B, and C. They are all diseases that cause liver inflammation and various symptoms related to that. They can be acute, meaning sudden onset and very obvious, or chronic, lifetime diseases. Liver damage can range from mild and again chronic, or to fatal in many cases. So we'll talk about hepatitis B first. This is significantly more contagious than HIV, and it can live for 7 days outside the body in dried blood. You can see there, these are dated figures from 2017, but 46,000 infections per year in the US, 1.25 million carriers, 3,000 deaths a year. There is no cure for hepatitis B. However, there is a readily available vaccine that is effective, mostly effective before, but also effective after potential exposure to hepatitis B. Ways that it's spread, the one that we're most concerned about here is sharps and needle sticks. We don't use a lot of needles in the medical treatment we do, but we do some. Symptoms, I'll go over this once because they're fairly common to the remaining bloodborne pathogens that we're going to discuss. So flu-like symptoms, weakness, fatigue, abdominal pain, loss of appetite, nausea, vomiting, joint pain, jaundice, common with liver issues. And the symptoms of hepatitis B usually occur within about 3 months of exposure. And that's what you'll see differ from disease to disease here. So the second one, hepatitis C, most common chronic bloodborne infection in the US. So a lot of people living with this. 12,000 deaths in the US each year. It's the leading reason for liver transplant. There are more effective treatments available these days than when the slide deck was prepared, but still nothing we want to expose ourselves to. IV drug use is ensuring needles is the main cause, has been historically the main cause of infections with hepatitis C in the US. Another, again, our most relevant issue here is needle sticks, occupational exposure to blood. So it is spread potentially in our environment. Symptoms are similar, plus dark urine, and then the difference here from hepatitis B is that they may occur a couple weeks or 6 months after exposure, but a lot of people may live with hepatitis C for up to 30 years and never show or notice the obvious symptoms of an infection. Brings us to HIV. This is, for all of its headline-making, interest in the U.S. and the world, is actually really fragile and a lot harder to transmit than hepatitis. Survives only a very short time outside the body. It attacks the body's ability to protect itself from disease. So it's an immune deficiency. 1 million or more people are infected in the US at any time. It's the cause of AIDS eventually, and vaccine's not available, but living with HIV is a significantly different prospect than it was a couple of decades ago due to treatments, medications that are available. Again, what we're concerned about here, needle sticks would be the main exposure, blood splash in the mucous membranes, as with any of these. Needle stick transmission of HIV is much more rare. It's harder to transmit that way than it is hepatitis. Symptoms, many have no symptoms, mild flu-like symptoms, a variety of diseases related to AIDS that eventually show themselves. And most people infected with HIV eventually develop AIDS, although treatments are significantly better again than they used to be at warding off that prospect. So that's the diseases. We'll move on to some of the technical stuff about how we are exposed to them in our environment and how we deal with that. So first, a difference between occupational exposure and an exposure incident. We all have occupational exposure in the process of providing medical treatment in the SAR environment. Occupational exposure is part of the job, and it's the reason that we're having this training. So we do get close with people, and some of those people's bodies may be broken. So there may be blood, there may be an opening in their skin, etc. That is different from an exposure incident, which means that something about our plan to prevent exposure incidents failed. So exposure incident would mean contact between our eye or other mucous membrane, or piercing of skin with something that is blood or other potentially infectious material, or may contain those items. So again, exposure is just why we're here. We have exposure, we know that, and that's what we're trying to deal with and manage. Exposure incident, we never hope to have one of those. That's what we're trying to prevent here. So possible occupational exposures to bloodborne pathogens. This is a list from LNI, and highlighted in red are the things that we may end up doing that may most apply in search and rescue. So handling syringes or other sharps, cleaning up anything that's broken that contains blood. And that doesn't necessarily mean just a bottle or something. That can be the vehicle or airplane or whatever it is that was cut and or was broken and cut someone and has blood on it. Other healthcare work involving exposure to bodily fluids, handling laundry contaminated with it, cleaning surfaces like the litter that's contaminated, disposing of hazardous waste, and providing first aid treatment. So let's talk about sharps first, because that's the headline, I guess, for ways that people get worried about infections. Is needle sticks. We don't do a lot of IV work in the field. We don't currently have paramedics, although we sometimes have them with us in the field. We could, though, check blood sugar, which involves piercing the skin and having a sharp. We could also administer epinephrine that is done with a needle, a sharp. So there are other types, including broken glass and anything else that's cut someone and might have blood or OPIM on it. But syringes are the big ones. So what do we do to reduce, first, our risk of infection if there is a sharps exposure incident? So this means that you have a needle, you've used it, say, to check blood sugar, and then you accidentally stab yourself with it. Your chance of actually getting infected from someone, if the patient were to have one of these 3 bloodborne pathogens in their blood, is pretty low, with the exception of hepatitis B. So HIV, you have a 0.3% or 1 in 300 chance of getting infected from that. Again, that's from blood that's known to be contaminated with HIV. It has HIV on it. You still have a very less than 1% chance of becoming infected yourself after poking yourself with that sharp. Hepatitis C is a little less than 2%. Hepatitis B is significantly higher chance. Again, this is what lives outside the body for up to a week. So 23 to 62% chance. I realize that's a big range. All that to say, it's the most likely transmitted bloodborne pathogen if your patient were to have it. The good news is, again, there's a vaccine. You can get it now if you don't have it already. You can also get it post-exposure, and it's still 90% effective. So there, thankfully, is an option for that one that's most transmittable. Still, despite the low odds of an infection resulting from an exposure incident, preventing the sharp injury obviously is still what we want to do. It's the best way to protect yourself from infection. So how do we do that? How do we, not just with sharps, but with all types of exposure, how do we prevent an exposure incident? So we have to have a plan, and the plan is this document you're looking at. It's required by the WAC, and the purpose of that plan is to eliminate or minimize the risk of an exposure incident. So it covers the topics that are required by L&I, determining what the exposures are, controlling them, communicating them, and following up in the case of an exposure incident. So things that we can do here in JSAR to control our exposure are these 4: universal precautions, safe work practices, use PPE, and have good housekeeping and laundry practices. We'll go through each of those in detail here. Universal precautions. This is something you should have heard before, regardless of your level of medical training. This should have come up. This is simply a system of treating all human blood and OPIM as if it were infected with a bloodborne disease. It ignores the question of trying to figure out if the person is infected or not. This means you don't need to ask someone, you can't ask someone, in most cases, whether they are infected with a variety of diseases you may be concerned about. You simply treat everyone from your best friend to the stranger that you just met on the side of a mountain as if they are infected by one or more bloodborne diseases. So you follow universal precautions in all situations. This is why we're always putting gloves on and eye protection, everything else that's appropriate. We don't evaluate the patient to see whether they look like a likely candidate to have a bloodborne pathogen. We just use universal precautions for everyone. The rule at the bottom is if it's wet, sticky, and not yours, do not touch it. So again, doesn't matter who it is, you use the same precautions every time. Other safe work practices. So if we have a sharp, we don't try to recap it, break it, remove it. I realize there might be some temptation to try to do this in the backcountry to deal with a used sharp. You don't do anything. It goes in a sharps container. That's the only thing we do. A water bottle is a sharps container, for example, if there's no other option. What is never an option is to try to put the cap back on that needle, or break that needle, or bend it so it's safe, or anything like that. That is how needle sticks happen. We remove gloves and other PPE before leaving the infected part of the work area. So if we're at a scene with a patient or a deceased subject, all that PPE comes off as we're leaving that work area, so we don't take that stuff with us anywhere else. Don't eat, drink, smoke, apply cosmetics, basically touch your face in any way, touch your contacts. You don't do anything like that if you're in that area or after that exposure. If any part of you has been dirty, treat your hands as dirty until you're able to clean them. Don't touch your face, don't eat, don't do anything like that. So food, drink, anything else that's personal that doesn't need to be done in the area around the patient or the subjects is forbidden there. So we have a clean area away from the working area, or if you need to rehydrate, for instance, or whatever. All of that should be kept far away from where we're working with the patient and the subjects. Okay, other safe work practices, wash your hands. This is always a question in the backcountry. We don't always have, a creek to use. So that's generally going to be waterless hand cleaner, and any kind of clean towel you can use to scrub your hands. Do that often. It's usually our only option. So make sure that you have that with you in your pack. Always have some with you. Encourage your coworkers on that scene. As soon as you're leaving the infected area, the potentially infected area, the work area, everyone get out hand sanitizer and wash really well. You're gonna want to wash up again when you get home. That's another topic, but do what you can early and often in the field to keep yourself clean, especially your hands. Okay, PPE. PPE is not an option. JSAR has to require, it shouldn't be a discussion, but JSAR has to require people to use PPE. So if you're dealing with a patient, you need to have gloves on. If that patient is wet in any way or squirty in any way, you need to have eye protection, face shields, rain gear as waterproof clothing and bloodproof clothing in this case. Anything that you can use and have with you to keep blood and OPIM away from your skin, away from your face especially, use it. So most notably, that's the hand and eye protection you always need to have with you, and then the hard shell layers that should be in your pack as part of your clothing layers. That ends up generally being our gown or our outer protective layer. Okay, disposable gloves must be worn whenever you have hand contact with anyone. Whether they're non-intact, their skin or not, just put gloves on. It makes the patient feel better these days as well. That's just the norm. You have to wear them whenever you handle items or anything that may be contaminated. Again, that's the litter or anything else, splinting materials, whatever was used to help treat the patient. If we're cleaning that stuff, put gloves on. If you're handling trash that came out of that incident, we brought a bag of trash back and it's in the back of the JSAR vehicle, and we get back to the front country and you go to remove that bag of trash, put gloves on first. It was packed in the back country. Nothing says the outside of that bag is clean. So put gloves on and then take them off and wash your hands when you're done. Sorry for the restroom thing. That doesn't really apply. Obviously, when you administer first aid or CPR, is when you're going to want to wear gloves as well. Gloves cannot be reused. They develop leaks. Change your gloves frequently. They will develop tears and all sorts of bad stuff with what we do. We have some heavier gloves that can feel a little thick for doing patient care, but they hold up a little better in our environment of thorns and sharp things and everything else we have to deal with. Just thin nitrile gloves they're not always up to the task, so you'll find them torn a lot. You can always put on 2 pairs. You can put disposable gloves over your normal gloves, whatever you want to do, or wear those heavier ones. But keep an eye on them. They will tear. They always do if you're doing anything remotely difficult in the backcountry. We do have some reusable gloves. We can wash them or decon them, but and obviously your normal working gloves fall into this category as well. If they're still forming a solid layer, they can be washed and reused, or they can be tossed and written off as a cost of that mission and reported as such. All PPE needs to be removed again before you leave the work area. You should be carrying a trash bag. All of us should. It's part of our 24-hour gear. So somebody's trash bag comes out of their bag and becomes the place where we put all the contaminated PPE. So one of those things can be actual trash. Another bag could be layers that we want back. It just needs to be laundered. Either way, it needs to go in bags and not worn away from the scene, but bagged up and removed kind of as cleanly as possible from the scene. Remove those garments as soon as feasible. Try to avoid contact with the contaminated surface, so you turn them inside out, just like you do with your gloves, and bag it up. Anything that gets contaminated, again, like the litter or the splinting materials, backboards, whatever else, needs to be cleaned. 10% bleach with water or a commercial cleaner that it's made for healthcare environments. Any reusable garbage can or whatever, if we use anything like that, also has to be cleaned. Anything that touches the patient or gets close to that scene needs to be cleaned before it's stowed. Handle everything as little as possible, whether that's your laundry or the litter, or whatever it is. As few people as possible need to touch it, and if it's bagged, it shouldn't be opened until it's at the place where you're gonna dump it in the washing machine or we pay someone to launder it. It shouldn't be handled any more than necessary. All right, moving on, the next topic we cover is the hepatitis B vaccine. This is provided free of charge to employees and volunteers at risk for occupational exposure to bloodborne pathogens. So that's all of us, all field CPR trained JSAR volunteers are eligible for this. It is a 3-shot series. The second shot is a month after the first, and the third is 5 months after that. It's effective for almost all people, and if you're in a high risk or an exposure incident situation, there is post-vaccination testing to see how well the vaccine took effect in your particular body. You may decline vaccination. Part of the test at the end of this is to say, yes, I want it, and we'll help you arrange that if you do, or to say, no, I don't, or I already have it. So you may decline it, of course, it's your choice, but it is not JSAR's choice whether to offer that to you or not. It is required that we offer it to you. Often that doesn't come at any cost to you anyway. Insurance covers adult immunizations, but if it does come at any cost at all, we will cover that. You can always choose, if you decline now, to re-elect to start that shot series at any time. For any reason, doesn't have to even be for a reason, whatever you choose. And then if you so choose, in discussion with your doctor, if an exposure incident occurs, you can be treated with it again at that point, even if you declined it earlier. And it's still, as I mentioned earlier, 90% effective at that time. So what do we do if we actually have an exposure incident? So this could be a needle stick, a cut, a splash of blood, or any other bodily fluid into the face, etc. We're out in the backcountry. We have few resources. Can't send you to the shower. So what do we do to try to minimize risk of infection? First, we thoroughly clean the affected area. We do what we can with that. So gather everyone's alcohol, sanitizer, anyone that brought some backcountry soap with them or whatever. If we can get to running water and irrigate really well, whatever we can do to irrigate, wash, flush, clean the area as much as possible, whether that's face or a needle stick. If we can retain the item, if there was an item that caused a needle stick or a cut, we try to retain that and take it with you. We can't always force results from a subject. We can't force results from a subject. We can ask, or medical providers can ask them to get tested. But if we have an item, a syringe or a sample, and it's safe to retain that and take it with the exposed volunteer to a medical provider, they can test what's remaining in or on that object, and give the volunteer some peace of mind, hopefully, that everything tested clear. So retain the item if possible for testing back in the front country, but again, only if safe. Remain calm. If this was a needle stick, for example, remember those stats earlier about how rare it is to be infected, even from a known infected party. It's which is unlikely in itself. The chance of being infected from that is even lower. So a very, very good chance that everything will come out clear. So keep calm, and we'll try to we or your supervisor, at least whoever you're talking to, we'll try to help you with that, staying calm and getting you whatever you need as far as resources and people to talk to. So you do need to inform someone, and up the chain of command, not just whoever you're working with right then. So you either need to go to whoever's acting as the SAR team leader from JSAR, a fellow volunteer, or if you prefer, go directly to the SAR deputy that is overseeing the mission. Either way, it needs to get reported. Either way, you will end up talking to that SAR deputy. So if you feel like keeping as few people informed as possible, just go directly to the deputies and complete whatever incident report you can do there. And then we'll direct you, JSAR will, in conjunction with the sheriff's office, direct you to a medical provider, your doctor or whoever else, for a post-exposure evaluation. That's where you start talking with the doctor. So we'll work with the sheriff's office in the county to provide that evaluation, any follow-up following any exposure incident. Remember that we're covered by the state mission number by the state for all costs related to injuries during a SAR mission and training or actual mission, and this is no exception to that. So this is at no cost to you as a volunteer that just got exposed. It includes testing, follow-up testing whenever you and the medical provider decide to do that. It includes preventative treatment where indicated, where recommended and agreed to, again, between you and the medical provider. If we have the source, again, if we brought that item, we can have that tested. If the person who was the source of the exposure consents, then medical providers can test and provide the results to you directly, again, to try to get you peace of mind early in the process. And again, with your consent, the medical provider would do a baseline test to watch for infection in you. Okay, a few other things. Everything that we put blood or other potentially infectious material in it must have the biohazard symbol on it. We have a bunch of red biohazard bags, and we can, in the backcountry, use any other thing that we have to use, given the lack of resources out there. However, this must be done in one way or another. So we all have Sharpies, we all have some kind of paper. We have ways to label things. So be creative and label it. Make sure that once something is in a bag, everyone who may encounter that bag knows what it is and knows not to touch it. Okay, employee records. If we ever have, fingers crossed that we won't, but if we ever have an exposure incident and have to go through the medical follow-up and everything, JSAR has to keep records on that for the length of time that you're with JSAR as a volunteer plus 30 years. That's the L&I requirement. It includes everything that that provider is going to furnish to JSAR, which will be generic. It won't be detailed. And they're going to do what the WAC requires, and we're only going to request and keep the paperwork that the WAC requires. We don't want to know anyone's health details beyond what the law requires to be in that file. So it'll be minimized as much as possible, but we'll have to comply with this law. It also includes vaccination declinations. So if you choose no, I don't want the declination, I don't want the vaccination for hepatitis B, or yes, I do want the vaccination and we pay for it. All of that stuff has to be maintained for 30 years as well. Okay, if we have a Sharps incident, we do have to have an incident log. That must be maintained for 5 years minimum. We haven't had one of these, so we haven't had to deal with it, but we will comply if we have to. And training records. So we have to keep all this, and it must be maintained for 3 years minimum. In reality, we keep our paperwork a lot longer than that, we and the state. Okay, that's the training. Please see the online test, complete that, and your training will be done for the year.